Hello and good afternoon, everyone. I'm Justina Cordance, as you can see on the screen. I'm delighted to welcome you to this lecture, which is a part of a wider project that the Ghana College of Physicians and Surgeons is involved with, in collaboration with the Royal College of Pathologists and the Tropical Health and Education Trust's Ghana Health Workforce Partnership UK. Together, we are developing a series of virtual learning resources across 4 specialties of laboratory medicine to support the implementation of our curricula that was recently revised. It's an honor to be joined today by Stephen MacDonald, who will lead today's lecture on the topic quality assurance in the coagulation laboratory. It's my utmost pleasure to introduce Stephen. Stephen MacDonald is a principal clinical scientist in the field of specialist hemostasis, working at Cambridge University Hospital NHS Foundation Trust in the UK. His key interests are in diagnosis of thrombotic and bleeding disorders, anticoagulation, and statistical assessment of laboratory assay performance and clinical trials. He's especially interested in the determination of the uncertainty of measurements in specialist hemostasis assays and in developing models to best describe their performance. I hope you all enjoy this lecture. I will now hand over to Stephen. Stephen, over to you.
Thank you very much, Justina. Thank you very much for the introduction. First things first, as usual, can we get a thumbs up? Can everybody hear me okay? Yeah, we got some thumbs up here, so that's a good sign. So yes, thank you very much for inviting me to speak today. This is a great honor for me, a great pleasure to be able to speak to you on behalf of my department and the Royal College of Pathologists as well. So hopefully this is going to be an entertaining and interesting and an illuminating session for you. A few housekeeping things, I suppose. There will be questions. I won't be able to answer everything. I don't know everything, so there's bound to be questions. What we'll do is, if you can just drop your questions into the chat as we go through, what we'll do is at the end, we'll collate all the questions and I'll work through them. And there will be an opportunity, should you wish to, as a participant, to unmute your microphone and you can ask me the question yourself, or if you'd rather, I can just read out the question and answer it as we go. So that's the housekeeping. My first slide, who am I? Well, Justina's given me a very kind and very thorough introduction there, so that answers that. I think, why am I interested in the topic I'm going to talk about today? Many years ago, I think I started developing more of an interest into the quality management side of laboratory testing, specialist hemostasis testing, and that probably came in parallel with a change in accreditation practices in the UK. Previously in the UK, we used to be accredited in the laboratories by an organisation called CPA, Clinical Pathology Accreditation, and round about nearly 10 years ago now, there was the beginning of a transition across to doing ISO 15189 accreditation under the UK Accreditation Service. And this was quite a troublesome time for us in the labs, because the requirements and the discussions and the points that were raised as part of that accreditation transfer were significantly different from what we were used to in CPA. There was a large degree of crossover, but there was a lot of new stuff that up until that point, perhaps we didn't consider to the extent that we certainly do now. And as such, I have developed quite a keen interest in both maintaining the quality management of our laboratory, but also developing research interests in there as well, to the point where I'm doing a PhD in measurement uncertainty, which Justina very kindly mentioned there, a topic that people are often very reluctant to talk about for any great length, but one which I thoroughly enjoy talking about. So with that in mind, what could we talk about today? The remit was, as the title of the talk suggests, quality management or quality in the laboratory, in the hemostasis laboratory. That could be absolutely anything. It's an absolutely massive topic. very wide ranging. And hopefully what I'll do is I'll focus on some of the more pertinent points of what I interpret that question to mean. As I said, what I usually say when I do these talks, I usually come out with a controversial statement that I absolutely love accreditation. And everybody always laughs at me when I say that at the beginning of a talk, because generally people hate accreditation because it's a very stressful time having somebody come in to inspect you and assess you and audit you and to look at your service and potentially find what you may think are faults within the service. I take a completely different look at it. I really take it on as a challenge and a way of improving our services to be the absolute best that they possibly can be. The problem is that the topic itself is so multifaceted that there's no easy, quick, streamlined, linear way of following through developing or maintaining a quality lab. And I think that's quite nicely shown in this diagram on the slide you can see here, in that there's a lot of interactions between different phases of laboratory testing. In specialist hemostasis particularly, this diagram is borrowed from quality and laboratory hemostasis and thrombosis by some colleagues in Sheffield in the UK. And that was published a number of years ago, over 10 years ago. But I think the concepts that they've discussed within that, certainly introductory pathway or part of the book, still stand the test of time today. What we are going to use that for is to try and discuss at a high level what's required of a quality system. What do we mean by a quality system? What do we mean by a quality system in a hemostasis laboratory? Because there are invariably idiosyncrasies within a hemostasis lab that apply to us that maybe we need to consider that other of our colleagues in pathology maybe don't need to consider. So it's worth talking about them. But once we've actually got a quality management service in place, that's not the end point. And actually, quite often, that's just the beginning, because we have to spend quite a large period of time and a lot of effort and man and woman power trying to maintain that quality management service. And that can be difficult when we are looking at the number of staff and the skill set of the staff that we have, because this is a complete change in practice that we've experienced over the last 10 years, which hasn't really been acknowledged fully by the people that provide us with the finances and the establishments of staff that we require, because the quality management is so much more prominent in our roles than it used to be. And of course, what we'll talk about at the end is common sources of error and how we can mitigate those potential errors within the laboratory. But I really want to draw your attention to the fact in this diagram that I'm a laboratorian. I work in a laboratory. I'm a clinical scientist. I like to think of myself as an interface between the clinical and laboratory services. But when I'm talking about quality management and quality engagement in any clinical laboratory, it is absolutely essential that the doctors and the clinicians and the laboratory scientific staff are working together in the same direction. We are both trying to get, as disciplines, both trying to get to the same goal, and one cannot do their job fully without the other. And it's really, really essential that we have that harmony between the different disciplines to be able to do that, because there's certain requirements that we have in the laboratory that we absolutely need clinical input for. And there's also things that happen in the clinical aspect of the doctor's roles that the laboratorians need to help them and need to support them with. And that may be in the pre-analytical phase, it may be in the analytic phase and the post-analytic phase. And again, this diagram really summarizes things really nicely, because when people talk about quality management, the things they immediately talk about is internal quality control, external quality assurance, measurement uncertainty, the statistical examination phase of what we produce in the laboratory, the tests and their results, for want of a better phrase. But the quality system encompasses everything that happens before we do a test and everything after once we've completed doing the test. And it's very, very important to remember that the clinicians and the people, the scientific laboratory staff, are integrally working together in both of those aspects. So if we think about a quality system, that there's two separate aspects to look at. If we think about managerial requirements and technical requirements, and we take them as separate entities, we can think about managerial requirements. That's really the framework that's held within the laboratory that enables the laboratory to provide a quality analytical service. And central to that is this thing which I will refer to throughout, called a QMS, Quality Management System. And that governs things like the organizational structure of the laboratory in conjunction with the clinical aspects, how we deal with equipment, procurement of equipment, buying equipment, maintaining equipment, having them on service contracts and various other things. And all of these things that are managed are under a very tightly managed document control system, so that if we have standard operating procedures and validation documents and the whole wealth of documentation that is required to support a quality management system, that these are controlled in a manner that means it's all very harmonized and it's all very standardized. We know we have the information to support any claims that we're making. We know where to find it, and we know that it's valid. We know that it's valid because we periodically review it, and we review it in the context of what the laboratory's needs are and what the clinician's needs are. And that'll be a big chunk of what I talk about in the coming presentation. Central to all of this management of the quality system is the things that we would traditionally consider to be quality management. Things like audit, non-conformances, and the actions that come as a consequence of findings within audits. So non-conformances, corrective and preventative actions, commonly called CAPAs, root cause analysis, 5 why analysis, RCAs, and new things that are specific to ISO 15189, but equally can be applied to other accreditation schemes. Things like cause and extent and review of effectiveness. So if you find something that is a fault or a finding as part of an audit in a specific test, is that something that's systematic across all of your workings? And if it is, how are you going to ensure that all of those things are fixed and all of those things are actually brought up to the same standard, so that everything is being managed to the same quality level? Secondly, and for those of us in the laboratory probably more familiarly, are the technical requirements. So how do we know that the results we're producing are good? And that's a very loaded phrase. What does good mean? How do we decide what good is? How do we check what good is? How do we determine what processes need to be in place to make sure that the maintenance of these good quality results are kept at the same level that we need it to be? And those technical requirements are delivered by people. So that sounds obvious, but highly qualified, highly technically skilled, well-educated people, well-trained, well-competency assessed people within the laboratory, as well as the clinicians as well. Are the buildings fit for purpose? Hospital buildings are always there's never enough space in hospital buildings, and there's never enough space in laboratories in hospital buildings. That is a problem everywhere. How does the laboratory manage that? And then the familiar processes that have been followed on through the CPA process of pre-examination. What happens from when the sample is first taken from the patient? So that might be out in the community, that might be in what we call in the UK general practice. It might come from another hospital, it might be from all realms of different places. How do we get the specimens, the samples, the tissues sent to the laboratory in a standardized way, so that when we do the tests, we know that that transportation and handling of the sample hasn't impacted on the quality of the sample and the results that we provide from that, and therefore the clinical outcome of the patient? And then there's the section that's most important, or that we have most control over in the laboratory, and that's the examination procedures. So laboratory testing and all that comes with that. But once, as I said before, once we produce a result, our role doesn't finish there. We have the post-examination procedures where we are sending results to the people that have requested those results, because fundamentally the workflow is generally patient is presented to a clinician determines what tests are most important based on the clinical presentation of that patient, and then as a result they need to know what the results of those tests are, otherwise they can't instigate clinical interventions or decide on a different diagnostic pathway if required. So it's very important that the quality system manages all of that so that the results that are needed get to the right place. But what is often the case, we find that quality management is a bit of it's seen as a bit of a stick to beat people with. People get very worried about quality management. A lot of people criticize it as, oh, it's just a paper management process. It's a lot of work that actually doesn't impact on patient care. And I disagree with that completely. And I saw this quote in a book that I read that really does, I hope, show a situation that I think is changing over time. But certainly over the last few decades, it was definitely the case that when we were having CPA accreditation or UCAS accreditation, people were doing what they felt was being inspected by the people coming in for the audit, and actually not doing what was being expected of their service. And there's a very subtle difference. And you can see from this reference that I've shown here, this is from a book that was published in the early 1980s. So this has been something that has been a theme within clinical laboratories for decades. Are we doing what is expected for a quality service, or are we doing something just to tick boxes to try and get through assessment schemes? But the problem with that is we need to ask the question, what is expected? And probably more importantly, who is making those expectations? Is it us in the laboratory? Is it people outside the laboratory who we're providing the service for? And I suppose a nice analogy to use is in a consumer and producer sort of aspect in respect to what you would expect in a business setting, where people produce something and then people consume what is being produced. So a consumer may be anybody such as our patient, and each and every one of our patients will have an expectation of what should be or could be provided to them with respect to laboratory services and pathology. Now, yes, they may have expectations, and sometimes those expectations might not be realistic. And it might be a case of how do we manage that in real time to manage expectations, both of patients or even the clinicians that we work with, to make them aware of these are the limitations of what we can actually provide. This is what we're doing to make sure that the provision of that service is to the absolute maximum standard that we have. But actually, sometimes we have to accept we cannot produce what is actually being expected from our users. But you can see here that the consumer may be anybody from an individual patient to entire organizational or healthcare systems. And equally, if we think about who's the producer, we could think about the laboratory being the producer because we're doing the tests and we're producing results. But equally, the clinicians who we are giving the results to are also producing a service to the patients as well. So this consumer and producer relationship that we quite often see in business is a little more blurred when it comes to clinical science. And I think that's, again, trying to hammer home the message that in some aspects we will be the producer, and in some aspects we will be the consumer as well. And that's why the interaction needs to be so much better than I think it certainly is at these days. And obviously, you do any sort of talk, you need a Venn diagram in there to show overlap of things. And if quality management is our goal in the middle here, then I think over time, I think there has been a separation of the the clinical and scientific expectation and management of what is quality management and quality provision, that I think is absolutely definitely moving towards what we're seeing in the right-hand Venn diagram, where the overlap is much more substantial, and we're seeing a much more synergistic effect of the interaction between the clinical and laboratorian colleagues, so that the quality management system is being pushed up. The standards are being raised so much more significantly now. Because again, the bottom line is we want all tests to be reliable, we want all tests to be transferable, and we want all tests to be clinically useful. And here's another question. We all agree that we want tests to be reliable, but what does reliability even mean? And from the same reference, the quality in hemostasis and thrombosis, a very nice quote in the foreword to that book is that the reliability of any particular assay that we perform in a laboratory, it should be viewed in the context in which the test is ordered. And that means things get a little bit complicated, because the expectations which I alluded to earlier need to be in the context of what the clinical utility of that result is going to be. And that might be different for the same test, because the same test can be used in wildly different scenarios. And how do we determine ourselves how an error, or how an unreliability, or how an increase in variance, or a bias, or all of these different terms, how do we determine when that becomes a clinically significant error that potentially can propagate to patient outcomes and can change the way that they are treated, diagnosed, and managed? So we really need to, I think the take-home message from quality management nowadays is we need to take what's in our heads, what we instinctively know as scientists in the laboratory, and what we know as clinicians in clinical science, and we need to document that, and we need to make that available to our users so that they know what our rationale is. If you ask anybody in a laboratory about any test, how does it perform, and is that good, bad, or indifferent, instinctively they'll be able to tell you, because they're used to running those things. But what we need to do is have that written down and have that clearly defined against certain standards that are defined in a standardized way. And a good example that, again, Fritz Rosendahl, who's one of the real powerhouses in hemostasis and thrombosis and has been for a number of decades, based in Leiden in the Netherlands, he likened it to measuring a simple factor VIII in a hemostasis laboratory that can be used in a lot of different scenarios. It can be used if it's at a very high level. Very rarely it can be used as a predictor of prothrombotic risk. If you get a factor VIII level of greater than 150, 200% of normal, you're at an increased risk potentially of having a thrombosis. But more commonly, we'll be able to use a factor VIII for things like hemophilia A diagnosis, or once we've diagnosed hemophilia A patients, treatment of those patients by monitoring replacement therapy. Now, a certain percentage of error will have a wildly different interpretation based on the level of result that we're obtaining. If we have an error of 5%, that will have a really significant impact at the very low levels of a factor VIII, because that will determine classification of the subclass of hemophilia A and potentially risk of developing inhibitors, treatment strategies, whether they need prophylactic factor VIII treatment or anything else. Whereas a systematic error of 5% at the 200% level has a much lower clinical impact on the patient. So we need to incorporate our knowledge of the assays into how we interpret the standards that we're setting for the tests. So how do we do that? And the way that I like to think of this is, and it's a way that I've been thinking about it slightly differently recently. And apologies if you're not using 15189 as your main standards. It's what we use in the UK. It's what I'm most familiar with. There's a very small clause within the 15189 ISO accreditation document for medical laboratories that states that there should always be a periodic review of examinations in the context of clinical requests. And it's a single sentence in what is a document that's about 100 pages long. But I think that single sentence is the absolute core of everything that we do as clinicians and as laboratorians in clinical science within pathology. I think it's a very cleverly worded clause because it has a lot of implied inputs into how do we determine whether something is still fit for purpose or not. And it goes back again to this point that I made a couple of minutes ago, which is getting the things out of my head onto paper. Because when I discussed this with an accreditation assessor quite recently, they were asking me about this. How do you do this? How do you do this? How do you do this? And I told them how I do it and did this, and they said, okay, where's the document that shows me that you do that? And it took me a while, and I found a line in a document that stated that, and then we had to discuss whether that was suitable or not. Since then, I've rewritten the documentation so that now I have an explicit explanation within my documentation. How do I periodically review that every test result that goes out of the door of my laboratory is valid for the purpose that it's been requested for? And that's very, very important. And what we'll do over the next few slides is we'll walk through some of the things that we need to consider as part of that. And some of these might be quite surprising, but again, they're encompassing the pre-analytical, analytical, and post-analytical parts, and also what's required from a clinical aspect and from a scientific aspect as well. Things such as, are the volumes of blood that we're requesting, are they appropriate? Are we requesting huge amounts of blood to do tests that actually we don't need that for? And therefore, are we indirectly causing harm to the patient, particularly in patients who are within a hospital setting, perhaps in intensive therapy, where they're being tested repeatedly over a prolonged period of time? If we're taking 3 or 4 samples a day and we're taking 4 or 5 tubes as part of each of those samplings, and we're doing that for weeks and months on end, eventually we're going to cause that patient to have a transfusion because we're just taking too much blood. Are we reviewing the volume that our tests require, and are we requesting the right number of tests, the right volume of blood to be able to achieve that? But also, are we making sure that we request enough blood so that we can do all of the testing that we need to do in a clinically appropriate time frame, and we're not having to recall patients back into phlebotomy services or inconvenience patients by having them to come back to repeat appointments in the hospital, wasting time, resources, and effort because we haven't taken enough sample in the first place. And that's linked, like I alluded to a minute ago, to the volume of testing. For each test that we do, are we able to provide a sufficient volume of testing, be that a number of samples for an individual patient, or more accurately, or more commonly, a population of patients, that if patients are being are having samples taken for that test, can we provide a methodology that can do it at such a scale that everybody will get the results in a proper time frame and of a sufficient standard, and that we're not relying on samples coming at certain times of the day or on certain days of the week for us to be able to provide results? Can we provide a service that can allow those results to be provided as quickly as clinically appropriate at a scale that is required for the individual population that we are serving? Can we review the number of test requests? We do this reasonably well in the laboratory. I think we have KPIs for workload assessments that we monitor quite closely, but we need to make sure that the number of tests, as well as the demographics of the patients who are having those tests requested on them, isn't changing significantly. Because if they do change significantly, then that might have an impact on what the requirements of our testing repertoire is. And we've seen this recently, and I'll come to this later on. We've seen this recently with a number of tests that we provide in the hemostasis lab, where completely different populations of patients are now having a test done, which we never used to test. And accordingly, we need to make sure that our testing strategy fits their needs as well as the established needs. Turnaround times are always a great favorite of any quality management service. Do we produce results quickly enough that they are able to instigate clinical intervention to patients in a clinically appropriate time frame? Now, that doesn't mean getting all results out as quickly as possible, because there's some tests that aren't required as quickly as necessarily are as we would necessarily be able to produce. What we need to do from a laboratory service is say, we don't want to hold up urgent tests because we're putting through loads and loads of routine samples that perhaps could be held back for a later time and the urgent samples prioritized. Again, a simple example of that would be if we have 2,000 community samples that are running through, and then suddenly we get an urgent sample from an emergency department. If we're not able to run the emergency sample through because everything's held up because of the high volume samples, we're not providing a quality clinical service to those in most need of the clinical service at that given time. How are those turnaround times determined? That's based on what the analytical availability is, what we're capable of producing in the laboratory. Somebody can demand that I produce a D-dimer result in 5 minutes. I can't produce that in 5 minutes. I can produce that within an hour. And if they need that clinically within less than an hour, then we need to discuss different methodologies of testing, maybe point of care or near patient testing, because the analytical requirements I just cannot meet. And obviously the clinical requirements balance that. So the clinical requirements will be one request, the analytical requirements will be another way of doing it, and we need to harmonize that approach. So again, the interface between clinicians and scientists is extremely important. And that's just reiterating that. Are we making sure that our tests are able to work in clinical scenarios where interfering substances and things that we're not measuring in the sample don't impact on the results? This is really important for hemostasis testing because a lot of our testing is involved in looking at enzymatic activities or coagulation factors, and even things like the prothrombin time and APTT are looking at a global measure of interactions of lots of different serine proteases and an endpoint of fibrin formation from fibrinogen. So there's lots of things that can interfere with that highly coordinated process. And we need to make sure that if we're testing patients where there's things in their sample that could be impacting on that our tests are capable of measuring in that context. So we need to know what the variables are. Common variables that we will see are things like hemolysis, icterus, and lipemia. And for a very long time, that has been an issue with hemostasis testing in certain subtypes of tests, particularly those that use light transmittance or light absorption, because of the color change that's associated with hemoglobin and icterus and lipemia. It was less of a problem, ironically enough, back in the decades where manual testing and coagulation tests using the tilt tube technique was used, because that was done by eye, and we were looking for fibrin endpoints and fibrin formation by eye. But as technology has improved, these interactions and these variables that impact on our results have become more of a prominent issue. And consequently, a few of the manufacturers, the suppliers of the automated analyzers, have provided ways of detecting hemolysis, icterus, and lipemia within samples, so we can set limitations to that. However, notwithstanding the fact that that is a real clinical issue in some patients that we are going to be testing, so in intravascular hemolysis, that might be a clinical symptom, a clinical outcome of certain tests that we are measuring, and we still need to be able to produce results in other tests which might be affected by that. And this is a big area of research of how do we interpret and produce results in that context where there may be clinically relevant interferences in the laboratory sample. And how do we manage the quality control in general in the laboratory? This is probably what people are much more familiar with when we talk about quality management in the hemostasis laboratory. This is a great topic that I have a lot of passion for. I'm happy to answer any questions at the end about specifics of management of quality control. We could have done an entire 3, 4, 5-hour session on laboratory quality control and hemostasis tests. These are the headlines, and these are the high level things that we need to consider, specifically in hemostasis, but in laboratories in general as well. We need to manage our assays in a clinically appropriate manner. That doesn't mean that we have a one-size-fits-all laboratory quality control policy across all of our assays. All of our tests behave differently. The expectation of all of our tests behavior is different, and therefore we need to have different expectations of how we control them. So I think that the days of doing 2 standard deviations for a quality control failure are gone now. We need to think more along the lines of our biochemistry colleagues and even more advanced methods than that, in order to be sure that when we quality control our tests, we know that the results that we are producing as a result of an in-control process are clinically acceptable. We need to know how to determine what is appropriate, and we need to know what evidence that gives that it does assure quality results. Much of that is through producing metrologically traceable procedures through quality control material that is traceable to international or as a minimum national standards, which means that a result in Cambridge is similar to the result in Ghana, so that we know that a prothrombin time or a factor VIII result in one specialist centre is equivalent to a result in another centre. And that goes back to one of the 3 things that I wanted to talk about earlier when I said they have to be reliable, they have to be transferable. The only way that we can have transferability of results is through having metrological traceability and having that encompassed within our measurement uncertainty calculations, so that we know what the result means between centres, because patients move. Patients don't necessarily get tested in the same hospital at the same time. So we need to know how that works. And what's coming more and more prevalent with that is the metrological calibration to the higher standard and the requirements of your suppliers to produce that traceability information. So don't worry that we have to produce the data for this metrological traceability. That should be provided by your suppliers and your manufacturers. But we can also supplement that using patient-based internal quality control by monitoring what the patient median is for the population in our given area, to make sure that there's no analyzer drift or assay drift, which we think is an unusual change in the performance of the assay, directly commutable to patient results. To supplement that, we also use, which I'm sure is very familiar to everybody, external quality assurance. So whereas IQC picks up random variability and systematic variability in a system, external EQA, as it's known, will tend to check how we are performing relative to our peers that are using similar analyzers, reagent combinations, and therefore can give us an indication as to what our systematic error or bias is across the population of people who are testing the same thing worldwide. It's extremely useful. It gives us a direct way of peer review. These terms are usually called proficiency testing. If there isn't a way of doing external quality assurance, we can do sample sharing across centres who are testing similar sorts of things or the same sort of things. And basically, at a high level, making sure we get the same result or a similar result to within an acceptable degree of difference, which has to be, again, linked to analytical expectations and clinical acceptability as well. So we're trying to detect, is there any bias? There will always be bias. If there is bias, how big is it? How do we find it? If it's so, is it to a size where it might be propagating to patient results? And if that is the case, is it causing potential problems to clinical treatment of the patient? So there has to be an understanding again of what is an acceptable bias from a clinician's perspective and what is an acceptable bias from the laboratory's perspective. How do we communicate that? So once we have got all of our results, we've made sure we've got the right amount of samples, we're providing the results quickly enough, the results that we are producing are of a sufficient standard locally based on our IQC, and also compared to our peers nationally or internationally. What do we do with those results? Because with the best will in the world, we can produce the best results in the world, but if we don't tell anybody about them, they're no use to anybody. So what we need to have is a process whereby we manage how the results get to our clinical users, so the consumers of our service, in a timely manner, so that identifiably urgent requests and results can be taken on by those clinicians, and then they can go on and do their clinical interventions as required. That's extremely important. In order to achieve that, we need to know we can't phone every result. So things like reference ranges, reference intervals, clinical cutoffs will determine what is an expected result in given populations of patients. Anything that is massively different from that, then where we think it will instigate a clinical intervention, we need to have a way of communicating that, be it by phone, messaging, or whatever. But we need to make sure that all of the results which reach those criteria are actually being correctly transferred to the clinicians. So in my laboratory, I have, I think, 10 different tests which have real prominent clinical urgent impact to a patient if they exceed a certain threshold. I do a download of our laboratory information system every month. I find all of the results that reach those criteria, and I make sure they've been phoned. If they haven't been phoned, then whoever the member of staff who was responsible for that didn't phone it has the discussion as to this is why this is urgent, this needs to be done in the future. So it's a key performance indicator for our laboratory. Moving forward throughout the whole process, even if we have the best tests available to us in our service, things are constantly changing in medicine, they're constantly changing in the laboratory. So do we make sure that we are keeping abreast of the latest developments? Are we aware of any other alternative examination solutions that are available? And are we considering them for implementation into our services? Because we need to know how do we manage to get them into our service from a financial perspective, which is a whole part of quality management that I haven't touched on yet. Is our equipment managed by an external company? Is it managed by you in the laboratory? Is it managed by a pathology-wide or laboratory-wide service? Is it contained within that? What are the financial benefits of that? How do you go about writing business cases in order to implement that? Because that will have a big impact as to how simple and how easy it is to implement these new tests, and has, again, an impact on how your service evolves with time and manages to develop to make sure that the requirements of your population of patients is being optimized. And part of optimization is considering in the last 12 months, are people over ordering the tests? Because the impact of over ordering the tests in clinically inappropriate situations, that slows down the clinically important tests. So part of that, again, is the discussion with a clinician, which I regularly have with our consultant hematologists, of our workload of this test is going up. Why has that changed? Is there a change in a pathway? Is this an increase in inappropriate treatment? Do we need to do some education? It quite often happens if you see new junior doctors being rotated around specialisms where they're unfamiliar. Sometimes they overorder tests that aren't clinically required. That's not their fault. That's because they haven't been educated. It's up to us in the specialisms to then educate them and say, in this scenario, this is the diagnostic pathway we would take. We don't want to waste resources. Laboratory tests cost money. Interpretation of those tests take time and effort and money. So if we can really focus on the ones that we need to do by talking with the clinicians and talking to the guys in the lab, that really helps us provide a better quality service. And in doing so, are there any future changes that we need to know about? that we need to be planning for in the following periods. So that might be in the short term, in the next 12 months, or longer term in the next 10 years. And this can be from a local clinical practice perspective or further afield at a national or international level. Are there going to be international guidelines coming out which is going to change clinical practice, clinical ordering and diagnosis? Are there going to be nationally commissioned pathways that we need to be aware of? That has certainly happened in the UK recently with my laboratory. There's been a nationally commissioned pathway which has changed the way that we need to deliver the service. So these conversations need to be had all the time with the clinicians and the laboratory, because the guys in the laboratory don't necessarily keep on top of all of that all the time, and the clinicians don't necessarily keep on top of the most up-to-date changes in the technology. So this, again, this crosstalk is essential. And part of that crosstalk is managing those discussions. So I've drawn a little tree here of the different meetings and interactions that we have where clinicians and laboratory staff discuss over different timeframes to make sure that all of these things are being covered. So laboratory staff keep abreast of things on a daily perspective from the laboratory management perspective, and we feed that into departmental quality meetings, so IQC, EQA meetings, which we have every 2 weeks, which then feed into the sort of multidisciplinary and directorate-wide managerial reviews of performance. So we have a performance review meeting, we have departmental multidisciplinary team meetings where, as the laboratory lead, I will go in there and discuss it with the consultant hematologists and the other users. And all of this is recorded within the annual management review. So that's part of the quality management system requirements, so that the sign off of new techniques and new requirements is constantly being monitored and reviewed. And what that does is that moves that Venn diagram, as I said earlier, into a more consolidated, integrated approach to maintaining quality in the hemostasis laboratory. But no matter what we do, there are always going to be errors. And there's always going to be things that we need to investigate or troubleshoot or improve, which will crop up periodically or over time that we need to investigate. So where might those errors come from? They could be from not setting up processes correctly in the first place, and that's a very common thing. And what we find now is that, particularly for those laboratories that are using techniques that have been around for a long, long time, what was acceptable when they were first implemented might not be acceptable now. And setting things to the same standards that they were in the 1950s, 60s, 70s is not the same as what we're looking for in 2022. So part of the periodic review of our examinations in the context of the clinical requests is considering re-verification of methods based on the changing landscape of tests that we do. So either not setting them up correctly or not reviewing them is a major source of sources of error, because if you do that properly, you pick up the potential sources of error before they even happen, which is essential if you think about stopping errors propagating to patient results. On an ongoing basis, laboratory staff need to be trained. We have new staff. We have staff that have been around for decades. They need different training requirements, but all staff need to be trained, and they need to maintain that training and competency in real time to reflect the changes in the requirements of the service, and also those things are well established within the service. So keeping on top of training, somebody can't be trained once then left to their own devices. There need to be spot checks, there needs to be regular assessments of that to make sure that when they were competent 10 years ago, they have maintained that competence, because people's roles change within a service as well. And things that they were doing 10 years ago are not the same things that they're doing nowadays. Even more so than particularly when I first started is the importance of maintenance and preventative maintenance and corrective maintenance on highly automated analyzers. The reason that that is more prominent now than it was when I started was that there's more analyzers. When I started, we used to do a lot of tests manually. So maintaining the equipment was maintaining the person. But now we have highly automated analyzers for some techniques, and we can't just plug in and play and add a sample to an analyzer and hope that it works well. We need to be monitoring that through our internal quality control and our external quality assurance, but we need to be doing preventative maintenance, much the same as people do with their cars, with services and MOTs and things like that. We have to maintain that standard periodically. It costs money, and it's money that never used to have to be spent in laboratories, but that's a conversation that you have to have with your finance department, and there's no avoiding it, because if you don't maintain your equipment, it will break, and if it doesn't break, possibly worse, it will start giving you bad results, which is potentially dangerous to patients. Okay, so if we move on now, so if we were talking here about common sources of error, we'll move on to the last section of what is error? How do we quantify error? How do we characterize error? How do we make sure that what we're measuring and controlling as error is something that can actually be done in real time and can be understood by clinicians and scientific staff in the lab alike? And there's actually, excuse me, there's actually a number of different ways we can do that. There's no one way of doing it. One is measurement uncertainty, which I've touched on previously, which is my thing, which is my obsession, if you like, which is a non-negative parameter which characterizes the dispersion of possible results around a measured result that you report, which is basically an acknowledgement of the result you produce is not the true result. It's a good estimate of the true result, and there's a degree of probability that the true result will be something around that sort of range. I think measurement uncertainty is an excellent way of characterizing error that is contained within results. It is one that is certainly used throughout Europe, and certainly those countries that are governed by ISO 15189 accreditation standards. That being said, there are different approaches, because measurement uncertainty does not incorporate bias as a measurable quantity into the degree of error. Measurement uncertainty assumes that systematic error, if it has been identified, by systematic error I mean bias, that has been corrected for, and only the uncertainty associated with that correction is incorporated into the measurement uncertainty calculation. Something that does incorporate systematic error are the metrics which are favored across in the US, things such as total error, total allowable error, which incorporates imprecision and incorporates systematic error as well. And what that does is you can take that to the next level and you can effectively give it a score, something called a sigma metric, which is something which has been borrowed from manufacturing industry, originally cars and mobile phone communication networks, many years ago, to give a number to your test, which gives an instant qualification of how good the test is. And that will be a result from 0 to 6, 6 being the absolute pinnacle of what we should be trying to achieve. Irrespective of which metric we use to determine the quality of our assays, none of it makes sense unless we make sure we have performance specifications assigned to that test. A result of 5 might be good, it might be bad, if we don't determine whether that result is good or bad before we generate that result. And the performance specifications can be different for application for, in this instance, measurement uncertainty, for when we're diagnosing patients or for when we're trying to check patients monitoring or the monitoring of the status of a patient over a period of time. So for diagnosis, we compare things such as reference intervals and clinical cutoff points, some of which are locally derived, some of which are nationally derived or guideline based. And the extent to which we vary our patient results varies from those expected reference intervals will determine what the probability is of them being clinically unwell. The uncertainty associated with the assay will have a massive impact on that. And it will also have an impact on how two different serial results in an individual patient changing over time is interpreted. If a random result of 10 changes to a result of 15, does that matter? It depends on the measurand that you're measuring, and it depends on what the performance specifications of that test are. So that's considerations that we have to have in the performance specifications of our test to drive that, that understanding. And again, I've said it a number of times, that understanding comes from the clinician and the scientist. And equally, the clinician and the scientist may have different perspectives of what they expect a result to be from a performance specification perspective. A clinician will be looking at things like clinical outcome studies, what the expected biological variation within a given patient is, both in a normal patient and in a disease state. Whereas the scientist in the laboratory will be looking at the analytical capability of the assay. And there must be an agreement of how that is combined and used. We're coming to near the end now. So again, just to reiterate the part that I touched on earlier on about transferability of results being driven by traceability of calibrations and traceability of methods to reference methodology, so that we know that a result in a given center is the same as a result in the other center. And as an extension of that, how do we know the result in the same center is always comparable over a period of time when we might have multiple analyzers, multiple hospitals working within the same network of hospitals? So you might have centralization of pathology services. You might have lots of different people doing the tests at different times. How does that impact the comparability of results? And things like reagent lot changes and reagent acceptance testing all feed into whether a result is traceable, comparable, and transferable. Deming, who originally was one of the first people in industry who developed statistical process control back in the 1940s, put it very nicely when he said a process is never optimized, it can always be improved. That is absolutely something that we have tried to embrace, and by using sigma metrics, I think we're certainly moving towards that. Another quote, which is less well written, I think, is that quality management in hemostasis laboratory is always a continuous process. We're never done, and especially when we think we're done, something changes, and we need to start again. And that quote is from me right now. There's always new challenges, there's always new perspectives. That's part of the joy of laboratory science. Those changes will be either clinically or from a laboratory perspective, and then again, that interface between the two will drive how good a quality the service is. I will conclude there. I was scheduled for an hour. I think that was an hour and 42 seconds, so that's not bad. We will go to some questions. So we have one question in the chat, which at this moment in time, I'm happy to read out. Sorry, this is in the Q&A, not the chat. Is there a way two laboratories with different methods or analyzers can run an inter-laboratory quality control comparison for a specific analyte? So I will say that, I will answer that live. Yes, thank you for the question, firstly. Yes, there is. And actually, sometimes that's the only way that we can do things. We have, for an example, my laboratory over quite a number of years have been trying to work out how we control platelet function testing. So platelet aggregometry, the ins and outs of the method aren't important, but what is important is that we provide a service for the whole of the East of England, and we get requests from hospitals which may be 2, 3, 4 hours away from Cambridge, and taking the time to get the samples delivered to us exceeds what the stability of the components that we're measuring are. So we had to think of a way of how can we manage comparison between different results in a sample share, which is what you're referring to there, while maintaining the stability of the sample, because traditional quality assurance schemes cannot send out platelet function tests to the entire country because the samples will always be out of stability. So The answer is yes, you can do a sample swap, ensuring that the samples that you are testing are within the stability of the measurand, which you will know. So that might mean for a plasma sample, you might need to spin it down, separate it, freeze it if possible, and then send it across frozen. But then what you can do is measure the different results across the different methods. Really where the intricacies come is then how you do the calculations of what is an acceptable performance specification across those two methods. And again, this is something that I've spoken to two people about this morning. Interestingly enough, we need to know what the difference between those two centers is within a clinically acceptable range. So if we say the results can differ by 10%, because any results greater than 10% difference will have a clinically different outcome between the two centers, then that's what we set it at. And the other thing to consider is if you're doing two different methods, it comes back to what things are traceable to. So if we have things that are calibrated assays that are traceable to the same calibrator, then it makes absolute sense to compare those results because the results that we're producing are traceable to the same calibration hierarchy that we have. Thank you for another comment. Just reiterating the fact that it's a waste of resources if the performance of laboratory tests do not impact patient care. Absolutely, I couldn't agree more. We have real, sometimes laboratory testing can be a numbers game, and it's about how many tests can we do in a very short period of time. And I think we need to really remember that, and what I always tell my staff in my laboratory, we may have 400 samples in the lab. Each and every single one of those blood samples is somebody's grandmother or child or husband or wife or brother or sister that has gone somewhere, had to go to the trouble of having a test taken, taking time off work, traveled a large distance, the emotional distress of having a clinical consultation. It's all very, very significant. We need to be testing people that need to be tested, and we need to be not testing people who don't need to be tested so that we can focus our resources on those people. Okay, thank you very much for the question. What is the cost of this quality assurance process? Can you put a cost to how much it costs to get this done and how this is financed? That is a fantastic question. I touched on that very briefly. Let me process that question. I have to be diplomatic how I answer that. It costs quite a bit of money, but I would argue not as much as it would cost if we got it wrong, which would be causing patient harm. So I think companies, there's different aspects, I suppose. There's the things that we do locally that we do with respect to quality control and EQA. Let's talk about that first. So IQC is generally provided by suppliers and manufacturers, and that's very well managed cost-wise because that's an essential. That's something that we cannot do without, and companies know that. In the laboratory, we will not accept companies who produce things that try and profiteer out of requirements to do that. EQA schemes, again, are very, very reasonable. There are a number of different EQA schemes available. And in the UK, I can speak for my laboratory. I use 1, 2, 3, 4, arguably 5 different schemes so that I can cover my entire repertoire. It's financed through the budgets that are given to the laboratory from the central financial budget from a divisional level. And I have a line in my budget which is for quality management of things like EQA schemes. The IQC costs are usually absorbed into the costs of the tests themselves. So if we were doing a prothrombin time, for example, if it costs £2 to do a prothrombin time, perhaps 10 pence of that might be the internal quality control cost, and the rest would be the test. The second part of the quality processes are the maintenance contracts that are maintained as part of the analyzer maintenance. They are expensive. And companies don't, unless you're on a managed service contract, which is something very, very different, they can be very, very expensive. But from a personal perspective, again, that is contained within a separate line of my financial budget. So I am given X number of pounds to cover maintenance contracts for all my test repertoire. The third thing, costs for quality management, is the costs of the people to manage it, and the discussions between scientists and doctors, as I keep talking about, that costs nothing. And the bulk of the value that will be taken away from a quality management system in a laboratory will be the discussions between the doctor and the scientist, and they don't cost anything. So they're good. Another question from where I sit: has quality control protocols been compromised in the face of COVID-19 pandemics? Has there been adjustments? That's another excellent question. The reason I say that's an excellent question is I was discussing this on Friday with the EQA provider, the main EQA provider for the UK, which is UK NEQAS for blood coagulation, who have international participants as well. And I know that NEQAS and ECAT, who are the Dutch equivalent, have done surveys of their participants to see how quality control practices have changed during the COVID pandemic. Because there's so many different factors which have caused that. Staff shortages due to sickness, change in working practices. My laboratory, for example, our test repertoire completely changed for 18 months. The tests that we were getting requests for virtually stopped because clinical activity had stopped, but there was specialist tests to do with COVID that completely changed, and new things that we had to test for, which I alluded to previously, which we then had to control for, which was different. So absolutely, I think the protocols have changed. Whether they've been compromised, I'm not sure. I think hopefully moving forward, what we've learned from COVID, the changes that we've had to implement to our quality control practices will be continued as far as good practice is concerned. I am confident from my service's perspective that quality control was still at the forefront of what we were doing, irrespective of what challenges we were being faced with. And I think that would be the case for 99.999999999 of laboratories, that despite the challenges that were being faced, maintenance of the quality control standards were still paramount. So from personal experience, I don't think they were compromised. I think they were changed, and I think we learned a lot from that. But thanks for the question. That's a really good question.